Assalamu alaikum. We are starting with clinical scenario. You are the senior house officer in the medical OPD. Mrs. Sarah, 25 years old, present with joint pain. Please see the patient and address her concern. We start in seconds after sharing the timer. Ready?
Yes.
Okay, here you go.
Hello.
Yes.
I'm Dr. Mahmoud, one of the doctors here in the clinic. Am I talking to Miss Sarah?
Yes, doctor.
Can you confirm your age?
Yeah, I'm 25-year-old, doctor.
Today I'm here to discuss about your health condition. I might ask you some question, and then I will continue. And at the end, I will address all your concern and answer all your questions. Is that okay with you?
Yes, doctor.
Okay, so I can see that you are coming complaining of joint pain. Is that right?
Right, doctor.
Can you tell me more about that?
Yeah, doctor. About 1 week, I start to feel this pain in my right knee, and it bothers me a lot. It affect I cannot go to work, and it affect my life.
I'm really sorry for that. It sounds quite distressing for you. And regarding your work, what you will do for a living?
Again, sorry.
What you do for a living?
Yeah, I'm a teacher, doctor.
And you're saying that this is affecting you too much, right?
Yes.
So I will assure you that we'll try to get the bottom of this today and address all your concerns. Coming back to this joint pain, it started all of the sudden, or it started gradually?
It start gradually and now worse.
Okay, and did you hit your knee by any chances?
No, doctor. I can't notice this.
Okay, and you notice that when you walk or move your joint, the pain is worse or it's improving?
Yeah, I think it is worse, doctor.
Worse. Okay, and have you noticed any stiffness in your joint?
No.
Any other joint in your body affected?
No, it's my knee just.
And in this knee, have you noticed it's swollen?
Yeah, I think it is swollen a little bit.
Any redness?
Yeah, I think also it red.
Okay. So and just to ask you some few questions, yes or no? Any fever?
No fever.
No fever with this pain. Okay. Have
You
you
mean hot, high temperature, right? No, I don't feel like this.
and even in the last few weeks, you didn't have any flu symptoms?
I had some sore throat about 3 weeks back.
So 3 weeks back. And how you dealt with that?
My doctor gave me some medicine, and now I feel good. So it is just 1 week and feel good.
Okay. And when you have this sore throat, do you have any other symptoms?
No.
Any change in your bowel habits?
I have changed in my bowel habits for a long time, about 1 year. Okay, and my doctor it is give me some medicine also for that, and it is just stopped about 1 month.
And you said change in your bowel habits. What do you mean? It is loose motion or you are constipated?
You have loose motion, yes.
And is this loose motion was containing blood?
Yeah, it was containing blood.
And what medications the doctor gave it to you?
It was put me in steroid for I think a few weeks. Not a few weeks, a few months, but now it's stopped this medicine, and they give me just other medicine, which is infliximab.
Infliximab. And and your loose motion is
Again?
Your loose motion is controlled medication? Now?
And now I feel better.
Feel better. Okay, that's good. Okay. So, and have you noticed any rash in any part in your body? You told me no, right? Or
Yes, doctor. I have skin rash for 2 years on and off, but recently also this increase and bother me a lot.
where rash? I think she's not here. Yes. Hello?
Yes, Doctor, I am sharing the rash now. You can see it on the screen. Okay, go ahead.
Okay. Okay, so this rash, it's only on your back of your neck, right? Hello?
Yes, I guess there is problem with Dr. Ibtihal. Wait, I'll pause the time first. 5 minutes exactly now. You saw already the rash?
Yes.
Yeah, Dr. Ibtihal, we can't hear you. You are on mute, but we can't hear you. Dr. Ibtihal? Yes, please rejoin back. I pause the time, Dr. Sarah, don't worry.
No problem.
Dr. Ibtihal, we can't hear you.
Yes. Okay, we can continue.
Yes, yeah, we can, but there is some noise around. Yes, okay now. Yeah, let's resume.
Okay. So you have this rash only on your back and your neck?
I have some rash also in my elbows.
It's the same as it. Okay. Okay.
It is small, not bother me a lot, but this is now it's a little bit also itchy.
Okay. You notice that this rash it's increased with exposure to sunlight or it's improving?
I didn't notice that, doctor.
Okay. And just I want to ask you, do you have any chest pain?
No.
Any shortness of breath?
No.
Any heart racing?
No.
Have you noticed any change in your water work?
No, normal.
Any frothy urine?
No.
Okay. And have you noticed any changes in your skin? It's become too loose or too tight?
No.
Any change in your weight?
No.
Okay. Any night sweat?
No.
Okay. And just to ask you some question, do you smoke? Regarding your social history, do you smoke?
No, I don't smoke.
And what about alcohol? Do you drink?
Occasional, doctor.
Occasionally. I just want to ask you, are you pregnant?
Don't think so, doctor.
Don't think. And any recent? Do you have any history of miscarriage?
No, doctor, I'm not married.
You are not married. Okay. And but are you sexually active?
No.
Okay. Okay. So, any recent history of travel?
No.
Any family history of note
No, doctor.
of clot?
No.
Okay. Okay, so I would like to examine you and I might ask some question. Okay.
Yes, sure, doctor.
First, I would like to check the vitals.
Yeah, your vital signs is stable. No, normal.
And then I will go to the right knee. I will examine it, check for the temperature.
Temperature is a little bit high.
High. And then I will see if any effusion or crepitus.
By what?
By manual fluctuating by put 2 finger above the knee and 2 finger below.
Doctor, it is it's very painful. I cannot move my. I
Painful.
cannot.
Okay.
You ask me, it's painful.
It's painful. Okay, so I couldn't. Okay, and then I will go to the rash to check for the rash that he's having. I can see that the rash is red and scaly, right?
Yes.
And you told me that this rash is
It is what?
itchy,
Yeah.
and you don't use any creams or medication for it?
No, until now, no, I didn't use something. It is on off. Before they give me some topical cream, but now I didn't sought any medical advice.
Okay. I need to check the eye if she for jaundice.
No jaundice, but there is redness.
Redness in the eye. So you
Yes.
redness since when?
The one again?
You have I can see that you have redness in your eye. Since when you have?
Yes, it is also on off, doctor, but about 1 month I have this. Not 1 month, 3 months, 3 weeks.
3 weeks. And painful or it's only red?
Yeah, it's painful.
Okay. So and you are not using anything for that?
No.
Okay. Now I would like to check the mouth for any ulcers.
No ulcer.
I will check the lymph nodes, axillary, the upper cervical, posterior auricular.
Normal.
Okay.
Normal.
Okay. I will listen to the chest for crepitation.
No crepitation.
The heart for murmur.
No murmur.
Okay. Mrs. Sara, what is your main concern?
Yes, doctor. What this pain, my knees very affect my life, so I don't know what is going on, and it is something controllable or no.
Yes. Okay. So I just want to after examining you, I think because you have this joint pain, it could be related to the condition that you have in your bowel, and you are taking for it the medication. It's this condition cause inflammation in the bowel, but sometimes it can cause some symptoms outside the bowel, as these joint pains that you're having. So that's why I need to do for you some blood tests to confirm the diagnosis, and will include a group of doctors, including the gut doctors, and also the skin doctor for the rash that you're having, in order your medication, and we might start to modify your medication.
Okay, but doctor, I have this problem in my bowel for a long time, and now I feel well. Why now I have this pain, this knee pain?
I'm not quite sure it could come. And can I ask you, have you noticed any stressful condition in your life, any recent stress?
No, other than what I said for you in my history, I didn't have something else.
It could be some immunological response from the immune system that cause that, and it can be triggered by stress, by infection, because you was having also, you are saying that you was having an infection a few weeks back. So when you have, can affect your defense mechanism and can trigger that. So that a flare, or mean a flare of the conditions that you have, and with it you have this symptoms which is outside that.
Okay.
Do you have any other question for me?
Yes, doctor. Also, I feel very low mood, doctor. With this skin rash in my under my hair. Any treatment for that?
Yes, I really appreciate that. I can see how it is concerning, and it's let you feel more concerned. So that's why I will include the dermatology team, the skin doctors, so they can give you some creams and some shampoo that can help you with that, and to help to relieve this rash. Okay.
Okay, doctor.
Okay, I finished.
Any more concern, or you want to examine, or you want to take another history? You want to ask any question? 2
No.
minutes left.
No.
Okay, let's start examine our questions.
Yes. Give me your positive point. Summarize your case.
So I examined this lady who was presented with joint pain, with inflammation, with acute inflammation of the joint pain, with severe tenderness and redness and swelling of the right knee joint. She had kind of, I think, inflammatory bowel disease, which is controlled steroid and infliximab. She's also,
What is yes, continue.
yes, she's also having a history of recent infection and sore throat infection, and she in her back of the head, back of her neck and her arms, with this mostly it could be psoriatic arthritis. So putting this all together, this patient might have spondyloarthropathy, enteropathic spondyloarthropathy, which is a group of disease common seropositive, HLA-B seropositive arthropathy.
So what is your differential now?
So my differential, it is I think she has enteropathic seroarthropathy, which is, I think, inflammatory bowel disease associated with psoriasis.
Okay, another differential?
Yes, another differential, it could be reactive arthritis. But from the history, she have only history of some sore throat. She doesn't have a history of gastroenteritis. She's not sexual.
You mentioned before psoriatic arthritis, something like that, right? You mentioned psoriatic arthritis, something like that, in the summary of the case.
Yes.
Okay, and other differential?
Reactive arthritis, it could be arthritis, but giving have any constitutional symptoms.
Yeah. Okay. So, yeah. Okay, that's good. So, what is the prescription of the pain of this joint? It is inflammatory pain.
Yes, it's inflammatory, not mechanical.
The patient said the pain is increasing with exercise, right?
Yes, increasing with exercise, yes. So it's mechanical pain, yes, right.
So what is the cause of this mechanical pain? All what you mentioned is just inflammatory arthritis. It is the cause?
Mechanical, not hormonal. Yes. No, I'm not quite sure.
Finish question?
Okay, no.
I don't know the answer.
Again, what?
I don't know the answers to this.
Okay, no problem. So this patient has this skin rash, and you said he has psoriasis. You suspect he has psoriasis, right?
Yes.
Or psoriatic arthritis. If this is mechanical pain, is it psoriasis or psoriatic arthritis?
If the pain is mechanical, you mean psoriatic arthritis? No.
Inflammatory psoriatic arthritis.
She doesn't have
Mechanical
inflammatory.
pseudogout osteoarthritis.
I didn't finish the question. I need to speak to the candidate. Okay. So
شفت
the pain
أردد
is
عليها.
mechanical. Yes, the pain is mechanical, and she has psoriasis, right?
Yes.
What is the relation between psoriasis and the mechanical pain of the knee?
I don't know.
It could be, what is the differential of the mechanical knee pain? You know.
The mechanical, it could be trauma. It could
Mhm.
infection.
Mhm.
Could
be gout.
Yes, it could be gout. Yes.
Yeah, and gout is one of the complications of psoriasis, right?
Gout. Yes. Yes. So you mean that?
Okay. So it is psoriasis with gout, complicated with gout. Okay. What is now? You need to answer what is the trigger of this psoriasis now in this patient. Patient, she said he has this psoriasis for 2 years on and off, but recently it is worse. Now you need to search about the trigger.
The flu symptoms that you have 2 weeks ago?
Yeah, so could be Streptococcus infection, other than this.
It could be stress, but she says she doesn't have stress.
Yeah, it could be, but he said also he has ulcerative colitis, which is also one of the association with psoriasis, because all we can have B27, B27. And she said she used steroids for a long time and she stopped it now. So withdrawal of steroid, one of the trigger of the psoriasis, right?
Yes.
This is other trigger. Also, she said the doctor starts for her infliximab, also another trigger of psoriasis. So she has a multiple cause or multiple trigger. It could be any one of them. Okay, so the withdrawal of steroid, the sore throat, which could be streptococcus infection, and also need to ask which antibiotic she received for this. Okay, because she said received antibiotic, and the infliximab, which is started for the controlling of the blood, the ulcerative colitis. Which she said not, she didn't say ulcerative colitis, but she said she has loose motion with red, with blood and like this. So it is prescription of ulcerative colitis, which is usually associated also. There is association between ulcerative colitis and psoriasis, okay, because both of them is HLA-B27.
Yes.
And they came sometime psoriasis with joint pain, which is gout, sometimes psoriasis with loose motion, which ulcerative colitis. So this is a common scenario, okay?
Okay.
So your role now it is to search about the trigger of this psoriasis. One of them is stress, the medicine, okay? Also, you need to ask about if she has any high blood pressure, because sometimes the beta blocker also one of the trigger, okay? And also this patient has skin rash. You need to ask her about the mood, okay? And she is female, okay?
Okay.
Okay, because it affects them. So now how we will go investigate this patient?
Yes, for this patient, I think she's already diagnosed with ulcerative colitis. So no bronchoscopy, no need for colonoscopy.
Yes, but you need to start with the recent complaint. Now she came with joint pain, okay? So we need to start to investigate regarding this.
Yes, we'll do the X-ray on the joints, and we'll do a full routine test, full blood count, renal function, liver function, inflammatory marker. We might do a joint aspiration to check.
Before this, uric acid, right? You said gout.
Yes, uric acid. Uric acid and inflammatory and joint aspiration. HLA-B27, but I think it has been done maybe for her.
Okay, no problem. You may have to mention whatever they done or not. This is your
Yes.
chance to say everything.
Okay. HLA-B27. So also we can do the colonoscopy to confirm the inflammatory bowel disease. And but her symptoms are improved. If she's not improved, we can do abdominal X-ray. If severe bowel symptoms.
She said her bowel motion now is improved, okay, in control already.
Yes. Yes. This is.
So you said joint aspiration. What do you suspect you will find?
For the gout, I think the negative crystals, but I forget. No.
Negative perfringin test.
Yeah.
And which crystal you suspected you found?
What?
Which crystal? We will check you will do the aspiration for what? For the perfringen test one, and what else?
No, I couldn't remember.
Okay. Okay, so how are we going to manage this patient?
I think for the management speech, this patient will treat for the gout. I think we'll give her allopurinol. We can. I think no, but we couldn't give colchicine, painkiller, non-steroidal anti-inflammatory drugs. No, but we couldn't also give an inflammatory bowel disease non-steroid. I don't know.
So I think firstly educate the patient, okay, and you can give her, for example, steroid and intra-arterial steroid if she need, okay, or colchicine, okay, or painkiller. But the most important one to stop the trigger, right? So we need to involve the joint doctor and you need rheumatology, okay, and the skin doctor and the bowel doctor also, because she need to stop the medicine and change with other medicine, okay. So mainly, as this is complication of psoriasis, we need to treat the trigger, treat the psoriasis, stop the medicine which precipitate the condition, and like this, okay.
Okay.
After that, if the pain continue, we can start for her like albuminol or something like that, or Vistat or other.
Colchicine for her diarrhea with inflammatory bowel disease.
Now she now she is. So at least you need to involve the joint doctor, okay? If you decide.
Yeah, this is the best. This is the best decision. If you are doubtful about the medication, what to give, what to avoid, what to prevent, so refer here to multidisciplinary team. Start by this answer. Okay, always start by multidisciplinary team approach. Sorry for interrupting you, Dr. Ibtihal. Yes, I guess we have discussion plus some question. So let's hear the comment first. Is that okay, Dr. Ibtihal?
Okay. Yes.
Are you done with the question, or you have another question?
No, done.
Okay, you can start commenting, please.
Yeah, I'm commenting. For me, that
what she has defect in and what she should do, like that. Just about the case, what she missed. Yeah. Okay.
Yeah, I think she started to analyze joint pain, and she didn't full analyze the joint pain. Although they said for her it is increased with exercise. You can also ask it relieved by rest or no. Is she received any painkiller for that? Okay. She need to go for differential of the mechanical joint pain, which is gout, osteoarthritis, septic arthritis, hemoarthrosis, like this. Okay. After that, yeah, there is she has the patient has a history of bowel motion, and I mean diarrhea for a long time, and there is after that, if you find after you finish the joint pain, the patient already, she said for her she has skin rash. So there is connection between psoriasis and the mechanical vein, which is not psoriatic arthropathy, because psoriatic arthropathy, enteropathic arthropathy, reactive arthropathy, all what we mentioned, it is inflammatory. Okay, but the gout is one of the known complications of the psoriasis. So now after that, you need to search about the trigger, what we mentioned already. Also, the candidate, she mentioned multiple jargon like fever, like immunological problem. So also she need to take care of that. Okay. Other than this, in the history, yeah, the patient she need to ask about the female history in more proper way. She need first to ask about if she is married or she has a partner. After that, she asks about the pregnancy and using of the pills and other things. So, and you need to take permission also. And other than this, I think she didn't ask about the past history also. Yeah. In examination, the welfare also, she didn't ask about the tenderness before doing the cavitation test because the patient would be in pain. I think this is my comment.
Yeah, thank you, Dr. Tihal, for the case. Nice scenario. And well done, Dr. Sarah. Although you mix between two
Yes, well done.
categories of, about arthritis. And I will give you now some hints about the positive, seropositive, and seronegative, and the mechanical. You should categorize which one you have. Your case today was about mechanical, and there is also seronegative, and there is also causes of seropositive. So what are the seropositive, Dr. Sarah? You know?
Seropositive, ankylosing.
No, ankylosing still seropositive, seronegative.
Yes,
So seropositive mean rheumatoid factor positive.
yes, rheumatoid arthritis.
Excellent. Yeah.
With
So
rheumatoid.
rheumatoid arthritis and SLE, systemic lupus, and Sjogren, yes, and dermatomyositis, polymyositis. These are the causes of seropositive. They are associated together. That's why we are calling them mixed connective tissue disease, and they are together. They present together, and once you take history, you suspect one of them, you have to ask about others. So this is first category. Whenever you have one, you have to screen for others. Okay, then we will go to the seronegative, which are not rheumatoid factor positive.
Yes.
What are they?
Ankylosing reactive arthritis.
Yes, excellent. And Behçet, right?
Yes.
And gout also consider one of them. But still, they are seronegative. And both seropositive and seronegative, they are inflammatory arthritis, means improve with movement, worse with rest. Okay, this is the main difference between both inflammatory and mechanical. But still, we are talking about inflammatory, seropositive and seronegative. Still, they are under the term of inflammatory. Okay, this is for first the difference. Let's go for the stiffness. How to differentiate between seropositive and seronegative by stiffness? The rheumatoid arthritis. How long they are stiff?
1 hour.
More than 1 hour. Others could be less than 30 minutes, but still they have stiffness. So you have to ask about stiffness in any patient with joint pain. Any stiffness for how long? These are the most important question to know what case you are talking about. You have either seropositive or seronegative, inflammatory or mechanical. How to differentiate between both? By asking about was it improving with the rest, or is it worsening with the rest? Or by another way, is it improving with movement or worsening with movement? Any of these questions you can ask, but you have to know what you are talking about. What's your case about? How the rest improve what? The mechanical, and the rest towards the inflammatory. The opposite, the movement improve the inflammatory, and the movement worse the mechanical. Exactly. This question you have to start with. Any joint pain in the exam, you have to start. Is it related to the movement, or it's worsening with the movement? Is it improve with the rest? Any question of this, but you have to know what you are talking about, inflammatory or mechanical. Once you finish, you have to go, if inflammatory, you have to ask about any stiffness. There is stiffness? Yes, doctor. For how long? Some stiffness in the morning. It's improve after certain minutes. So this you are talking about seronegative. No, it takes more than 1 hour. So you are talking about rheumatoid, and you have to screen for seropositive. Clear now? So you have to start first by the pain or the movement or the rest. First question. If you got this is inflammatory, you have to ask about stiffness. But if not, so it's mechanical. So don't ask about stiffness. Okay? Clear now?
Okay. So the
Okay, this is
stiffness, the
yes.
seronegative, no stiffness, or what? I didn't get the
There is stiffness, but less than 30 minutes.
Ah, okay.
And closing, there is stiffness, right?
Yes, yes.
Yeah, evidence by what? Limited movement of the back, limited movement of the neck, sacroiliitis, isn't?
Yes.
So there is stiffness. The mechanical, but this is stiffness improve with the movement. The mechanical, he can't never move because of the pain, or the pain will worse the pain. So, okay, the pain will worse. Sorry, the movement will worse the pain. So he can't move. If he has septic, he can't move because of the pain. And also the other mechanical, as Dr. Ibtihal said, gout, pseudo-gout, osteoarthritis, hemoarthrosis, trauma, all these will worse with the movement, right? You know that now the causes of hand or joint pain? Is it
Yes.
clear?
Yes, clear.
Okay,
Thank you.
let's count them again. First of all, the seropositive, which are
Rheumatoid arthritis,
rheumatoid, dermatojugular,
Yes.
SLE,
Mm.
systemic sclerosis.
Okay.
Seronegative,
Ankylosing psoriasis,
ankylosing, reactive,
and Behçet.
Behçet, and gout,
And
because gout always differential to ankylosing. By the way, they are associated together.
Psoriatic also was.
Psoriatic always associated with ankylosing. So they are seronegative together. You have to ask about both together. Whenever you have back pain, you have to ask skin rash. Okay, especially the back pain, because sometimes they are coming as axial, mean the vertebrae and the axial joint. Okay, sacroiliitis or the back. Okay, the mechanical, the last causes. What mechanical you know?
Osteoarthritis, septic arthritis,
Excellent. Yes.
and she said gout also.
Gout, because yes, yes, sometimes considered as mechanical, but it's still under the term of seronegative. But it works with the movement. But I guess it's inflammatory in nature. Okay, especially if complicated with osteoarthritis, because the gouty joint always liable for complication of osteoarthritis. So you can consider it as, especially if infected. Okay, let's go to the other cause of mechanical. Trauma and osteoarthritis and hemoarthrosis. Yes. Okay, please consider gouty arthritis under the term of inflammatory seronegative.
Okay.
Okay, the mechanical are known: septic, and as you said, trauma, hemoarthrosis, and osteoarthritis. These are the mechanical cause. Okay.
Okay.
Okay, let's go to the comment.
And
Other comments.
pseudo-gout.
Yeah, pseudo-gout also. Pseudo-gout also mechanical.
الجوت not mechanical increase in movement برضه.
Gout, yes. Let's go back to the nature of the gout. The gout is associated with ankylosing, right? And it's also HALA HLA positive, right?
Yeah.
There is association. But
يعني معاهم الإسمون ولا بقول إنه
yes,
أقرب
could be, but under the term of inflammatory more. But it can be like mechanical pain, yes. Sometimes because of the precipitation, it will be like mechanical one. But in nature, it's inflammatory one.
Okay.
Okay.
Thank you.
Let's go to the comment about the case. As Dr. Ibtihal said, you have some jargon, which are fever, and you said also inflammation to the patient. If you want to say inflammation, you can say soreness in the joint, soreness in the bowel, And you have to know what she has in the bowel exactly. You didn't ask her. She said I have some bowel problem. What is it? You
No,
didn't ask.
told me loose motion, not constant.
Yes, and under the term of what?
Blood.
You didn't ask what past medical history.
She told me she has a medical condition and she's taking medication. She didn't say the disease.
Ask her what disease you are diagnosed with. It's okay, you can ask, right? She can tell you, yes, this is, for example, ulcerative colitis. Could
I
be.
think that she doesn't know. Sometimes make it that they don't know the disease. That's why I assume that. But you are right. I need to ask.
Yes, ask it.
Yeah.
Why not? You can ask, and she can pronounce it easily. She will tell you ulcerative colitis. She can say, no, doctor, I have some gastroenteritis, and I took some antibiotics. So you can think about, yes, enteropathy here, as you said.
But fever is not a jargon. We are not considering here fever.
Okay, sometimes, yes, in your clinic, you can ask a clear question as a fever. So sometimes there is doubt about jargon or not, but you can be simple as much as you can. If you said body temperature, he will not catch any mistake. The examiner, I mean. Some examiner consider like that. So be clear and be simple as much as you can. Say high body temperature. Sometimes, yes, it's considered not jargon, but you don't know who's examiner sitting in front of you. Really,
Yes.
and 1 mark can be I mean you can miss 1 mark to pass or
Yes.
1 mark to fail. So don't let some examiner, some of them, wallahi, they are stupid. For small mistakes, they are deducting your mark. For stupid, not small, stupid mistakes.
Yes.
And you will feel regret when someone write in his comment, she mentioned fever in the jargon.
Yes. You're
Okay.
right.
انتوا
Yeah,
بتقولوا
better
لي الجار
to be
ان انا
simple.
قدمت بس الدكتوره قالت لي ما المفروض تقولي فيفر ثاني جديده اول كيس اقدمه في حياتي قالت لي المفروض تقولي ريز بودي تمبريتشر او اني هاي بودي تمبريتشر قالت لي
Yes, but
fever.
mm, some doctors, they consider it like, okay, because fever, all of us know fever. I
طيب
mean, even
هنا نكون في السيف نقول
yeah,
الحاجه اللي
for exactly, be simple as much as you can, so the examiner will not catch any mistake for you. Sometimes you are saying it, and he will just write it, and he might fail you for very small and stupid thing, and he will deduct your mark for this thing.
Okay.
Okay, just try to use it whenever you are practicing. Use high body temperature instead of that. Okay, again, for the history, you didn't take clear and full, complete female history, not only any pregnancy. Are you pregnant? Better, before asking, are you pregnant? You can ask before that, do you have any partner? Because as in this question, does it make sense to ask about pregnancy and she doesn't have any partner? Right? So the best way to ask or to start with, do you have a partner? Yes. Are you pregnant by any chance? No. You have any miscarriage? You might ask all these questions and she doesn't have any partner. So what's the benefit of this question, right? You got it?
Yes, yes.
Yeah, okay. This is for the female history, and you have to take this history, full history. The travel you ask, the job, the occupational, the social. Yeah. And once you have gout, you have to know what the trigger for gout. Okay. So as a complaint, as we said always, we are starting by complaint analysis and what the serious or the complication form of the complaint. In gout or any joint problem, what's the serious condition of this complaint? I mean arthritis. What do you think? After analyzing the joint pain, what do you think is serious in the joint pain? The most serious joint pain ever.
exclude septic.
Excellent. So you have to exclude septic by, you ask about the high body temperature, lumps or bumps, and loss of weight, and or any history of infection before. This question to rule out the serious form of the complaint. I'm always saying that. Ask about the complaint and the serious form of the complaint. Joint pain? Yes, I have joint pain. What you suspect to have after the joint pain if she has something serious in the joint? will be septic arthritis. So you have to ask about septic arthritis. Okay, you have gout arthritis. You have to analyze the gout itself, the skin rash, where exactly, the shiny, scaly, and any oozing. You have to ask all this question, any sensation over it, and the distribution, okay? Then the joint itself, any joint, other joint pain as you did, and what the trigger for the gout. A lot of trigger factor in the gout. The food, the diet itself can cause the gout, the meat, I mean, and also it's associated with uric acid, so you have to ask about any urinary system or stones. You have to ask this question. Other medication can be, as doctor said, beta blocker and infliximab, sudden withdrawal of steroid, sun exposure. All these trigger for, you have to know what's your trigger. Sometimes also thiazide can trigger for uric acid, and it will cause also gouty flare and stone.
But
Okay.
sun exposure is the psoriasis. It's not increasing the psoriasis.
Yes,
Oh, okay.
yes,
No,
the psoriasis associated with, we said it, gout.
yes, but you say
Psoriasis as,
triggers
yes, at the
trigger.
turnover of the cells, uric acid, right?
No, but you're saying the triggers of psoriasis sunlight, sun exposure. No, psoriasis is the sun exposure is not triggering the rash or increasing it.
So what's the sun exposure?
I think
It's not
sun
trigger
exposure, it
for
will improve psoriasis,
improve the
yeah.
rash?
Yes,
Improve
yes,
the
Really?
psoriasis, yeah.
yes,
Mm.
yes. No, it's from the cool
Okay,
of the rash.
okay, mistakenly. I guess it's worse because the
No,
redness
lupus
worse
is
with the skin.
destroyed.
It's worse by trauma, other what you mentioned, but
Trauma,
sun
yes,
exposure, it
yes, yeah,
improves.
but not sun exposure. Okay,
Yes,
okay, so
psoriasis by sun exposure.
okay, good to know. Thank you for correction. So they are correlating to each other, the psoriasis and the gout. That's why you have to screen for both together. Okay.
Okay.
Apart from this, the examination, yes, you have to do the joint itself, and you can do for the lymph node and other joint, especially if you suspect enteropathy or reactive related to the urinary system. You have to offer for any discharge, and you can offer for inguinal lymph node. Okay. This is my comment, but at least now you know the three categories of joint pain you have to know about, and you have to screen the association together.
Okay.
Okay. Any question from others? Please, let's. Okay, write your scenario, Dr.
Okay.
Tihal, for Dr. Sarah.
Me, I will write for her.
Okay, Dr. Sarah, write for Dr. Tihal. You started today first.
Yes.
Okay. Against the nature. Yes, tumor can be the trigger. One of the trigger, psoriasis, sun exposure. Yeah, so it's corrected, not sun exposure. Sun exposure improve, not worse. Psoriasis also negative. Yes, psoriasis is one of the negative. Okay, the Dr. Tihal, patient Mr. Michael Scott, 37 years. This gentleman has suffered gradual loss of vision. Take a history and examine appropriately. I will give you 2 minutes, then we can start.
Okay.
Dr. Sarah, whenever you don't know or you are not sure about medication, please start multidisciplinary team approach for the management.
Okay.
Okay? Even you don't, you know, the best way and the safest way to start answer of management plan to refer the patient to multidisciplinary team approach. Then they will decide how and what to stop, what to start, what
Yes.
to do. Okay? If we insist for the question, what medication you want to do, what medication you want to start, what surgery, then you can answer. But don't start without mentioning multidisciplinary, especially if multi-system disease, like the previous patient. You have rheumatologists, you have also dermatologists. Why not to refer the patient to all this team and they can do the best interest for the patient? If he asks you what medication you know for example for gouty arthritis, you can say yes, non-steroidal anti-inflammatory, as we know, the first line. And for the flare-up, we have to avoid the exposure or the trigger factor. Alcohol here is very important. You have to advise about this is for the gout. For the psoriasis itself, you have a lot of options for the topical steroid, also some camouflage. You have also vitamin D. Yes, up to if you have joint, I mean psoriatic arthritis, you can think about methotrexate. So you have a lot of options, but which to be mentioned according to multidisciplinary. But if he insists to know if you are knowing these medication, then you can enumerate. But don't say, yeah. If you don't know, the best answer ever when you don't know, multidisciplinary team approach. If you don't know about the pharmacological, you can say education, counseling. You can waste some minutes or some seconds at least before reaching to the pharmacological. You have a lot of things to mention in the education. Don't avoid trigger, avoid alcohol, avoid stress, avoid trauma. This will take some minutes, which give you more marks, even without knowing what medication I can give.
That's
Okay?
right.
Be
Okay.
smart while answering the examiner. Okay.
Thank you.
Dr. Ibtihal, you ready? Most welcome. Ready, Dr. Ibtihal?
Yes.
Okay, let's
Yes.
start. Here you go.
Hello there.
Yes. Hello.
I'm Dr. Mahjoub, one of the medical doctor in the clinic today. May I confirm you are Mr. Michael?
Yes, I am.
Are you 37-year-old?
Yes, doctor.
So, Mr. Michael, we are here to ask you some questions regarding your recent health problem. I would like to ask you some questions, then examine you and address your concern. Is that okay?
Yes, please.
Okay, Mr. Michael, can you tell me what brought you into our clinic today?
Yes, doctor. I have noticed that I started have problem with my vision, and quite concerning me. That's why I came to you to see what's happening exactly.
Sorry to hear that, Mr. Michael. So this is first time you have this problem?
Yes, this is the first time.
And since started, how many
والله ما ايش
since when started?
لسه
Yes.
شويه يمكن
Started, I think I have started about 6 months ago. And
6 months ago, and since and since it started going worse, same or better?
no, it's going worse. At the beginning, I didn't notice, but then I'm to notice I'm more worse.
Yeah, sorry for that. But and this is sudden or gradually?
Gradually.
Okay, and what do you mean about vision problem? What do you feel, or what is the problem exactly?
I feel that my vision started. I couldn't sometimes see some when I'm sitting in front of me. I couldn't see the side. What is this also while driving? Sometimes I'm next to me. I see that's no one, and then
So you have a problem. Yes, I understand that you have a problem to see the side of the road, right?
Yes.
Okay. And this is in both eye?
Yes.
Any pain?
No pain.
Okay. Any problem in the night vision?
This is. I think it's more also at night because at night it become more dark here. So I think it's more.
Okay. And do you have any problem with the color vision?
No.
Any problem in the the item which is far away? I mean the far vision. Any problem in the far vision?
Yes, I think also this affected, but I'm not quite sure. Yes.
Okay, that's good. So you have any headache with
No.
this? No headache, right?
No.
Okay, and do you have any body weakness?
Body weakness? No.
Yes. Okay. Anything you experience, you feel this increase this problem, like any problem like a hot bath, anything, any
No.
worse this problem?
No.
Okay. Do you use anything make it better?
No, nothing make it better. That's why I came.
Okay. Do you sought any medical advice regarding that in these 6 months?
No, I didn't. I went to the optician. They told me, give me some glass, which they give me some glass. It's helped me. And I'm still also, it's progressive.
Okay. Okay. Sorry for that. And you have any family history of similar problem?
No, I'm adopted.
Okay. So regarding your driving, I need from you to stop driving until control your problem. Is that okay?
Okay.
Okay. So besides this, you said there is no any weakness in your body, right?
No weakness.
No any history of falling.
No, sometimes I'm tripping over and bumping into things.
Okay. And this because the problem of the vision itself, or because you feel unsteady?
No, I'm not quite sure, but it started also with my vision.
Okay. And do you have any numbness or abnormal sensation in your your body?
No.
Okay. Do you have any problem in your memory?
No.
Okay. Do you have any problem in your swallowing?
No, I don't have problem in my swallow.
Okay, that's good. And your speech?
My speech is good.
And how is your performance in school before?
It was normal.
Okay. Okay. So other than this, you have any joint pain?
No, I don't have joint pain.
Any skin rash?
No.
Any change in your bowel motion?
No.
Okay. Do you have any back pain?
No back pain.
Okay, that's good. And do you have any high body temperature?
No.
Any change in your weight?
No.
Any bumps or lumps in your body?
No.
Okay. And any weather preference?
No.
Okay. And do you have any change in your water work?
No change in my work.
Any froth urine?
No froth urine.
Yeah. Okay. Sorry, Mr. Michael. Do you have any hearing problem?
No, I don't have hearing problem. I'm hearing you well.
Okay, that's good. Okay. Do you have any chest pain?
No.
Okay. And any cough?
No.
Any past history of knots? I have to know about it.
No past history.
Okay. And do you have any medicine using for a long time?
No, I'm not using any medication.
Any allergy to any medicine?
No allergy.
What about your diet? Is it balanced diet? Taking
Yes.
good diet. Okay. And exposure to sun usually?
Yes, I'm exposed to sun. We don't have.
Okay. Yes.
We don't have sun here, so there's not too much sun to be exposed.
Okay. So, what is your job, Mr. Michael?
I'm working as an accountant.
And what impact this problem in your life and your job?
Yes, it started to impact me. I told you I'm starting to trip over something, not seeing something on my sides. So I'm thinking affecting my job.
Yeah, sorry for that. Okay, I will do my best to help you regarding that. Okay.
Okay.
So, Mr. Michael, I'd like to ask you some private question. Do you smoke?
No, I'm not smoking.
You drink alcohol?
Yes, I'm drinking alcohol.
Do you drink much alcohol or it is in limited?
What do you mean by limited?
How many you taking per week?
Per day I'm taking about 4 glasses of wine,
Okay.
and
We
sometimes
need for moderize alcohol intake. Okay.
okay.
Okay. So, are you married?
No, I'm not married.
You have partner.
Yes.
Okay. Do you have kids?
Yes, I have kids.
Okay. Anyone have the same problem?
I have one son, he's 4 years, and one girl 6 years. But I
Okay,
noticed that, I don't know.
that's good. Okay, and do you have any history of, sorry for this question, sharing needles, tattoo?
No. Sharing
Okay,
needle,
so
what do you mean by
yes,
needle for what?
I mean using for any not sterile needles, any using of any drugs. This is usual for this is for usual questions for history, checking history to exclude all causes.
Means that I'm taking drugs.
Drugs, yes.
No, I'm not doing drugs.
Okay, that's good. So what is your concern, Mr. Michael?
I'm concerned about my vision. Would I be blind?
Yeah, this is very bad concern. I will do my best to answer this question, but after examine you, okay?
Okay.
So I would like to start from the visual acuity, okay? Firstly, I would like to check the vital sign,
Normal.
the blood pressure, the random
Blood pressure normal.
blood sugar.
Normal.
Okay, I will check the visual acuity. I will stand far and ask the patient to close one eye and count the finger.
Yes, he has decreased visual acuity.
So he can see the finger in nearby, for example, 1 meter.
Only count. You are doing counting finger. You are not using the snell chart.
Okay, if it is available, yeah.
Yes, there is
There
a
is
snell. Yes, there is
Okay, in both sides.
in both sides.
Okay, I will check the eye movement.
Yes,
Is
eye
it
movement.
possible?
What you want in eye movement? You mean to
I
check?
want to see. Ask him if do you see double or you have pain? Tell
No,
me.
no double
Or
pain.
there is a side you don't see.
Yes, when you check the visual, I think he has. You will find the periphery visual field is affected
Okay.
on both eyes.
Okay. So yeah, that's fine. I will do fundoscopy now.
Yes, you
If
might.
there is
Any what?
any positive finding this fundoscopy, like specular shape, black in
Yes,
the periphery?
the specular shape.
Yes, okay. I would like to check also the visual field if possible. He can see.
I thought
There is a temporal loss or
it's
no, or relation.
in the visual field, in the lateral field, in the peripheral field on both eyes.
Okay. So, okay, I will check, I will ask the patient to do pronator drift for upper limb. Any weakness?
Negative.
Okay, I will check also the hearing, both ear by,
No.
Okay. I will check also the sensation is okay.
Normal.
Okay, I will check the post pointing and the intention tremor. There is any problem
No.
in this dysdiadokinesia?
No.
Okay, I will check the patient gait also.
Normal.
Okay. Okay, so Miss Michael, from what you said to me, and after examining you, we're thinking about condition called retinitis pigmentosa. It is medical term of medical condition where there is problem, okay, in the vision due to the position of small of special dye, okay, or yeah, in the peripheral of the vision. For example, this I will draw for you. This is the eye, okay, and there is here some deposition of some spot or dye in the peripheral of the vision lead to this manifestation what you have, like the difficulty of seeing in the night, and difficulty to see the road, the side of the road. Okay, and usually there is multiple cause of this, but most of them it is something running in the family. Okay, due to some problem in the inherited, or I mean the inherited protein. Okay, so now what we need to do, we need to do for you further tests and some imaging also, and we need to involve a group of doctor, including the nerve doctor, okay, and the eye doctor. Okay, so they will sit to you and start for you the suitable plan of treatment. And
2 minutes.
regarding driving, you need from you to stop driving. Okay, and also regarding your work, I think if you have, it will be quite difficulty regarding this. So we may involve the occupation health worker. So we will see how he can help you regarding this. Okay.
So you mean this is this condition run in family, right?
Most likely, yes. It's
So
most
my
causes.
have it?
Again, sorry.
My kids will have it?
Yeah, there is possibility of this, but we need to do for them also further genetic test and to be sure that he has the same problem. Sorry for that.
And this is not, this is not a treatable condition?
Again, sorry, so your voice is not clear.
Not a treatable condition? I will be
Yeah,
blind?
sorry for that. Yeah, sorry for that. This is something progressive, okay? I mean, this is something it can worse with the time, okay? Most likely, yeah, to be blind is one, it can be possible, okay? So we'll do how we can help you regarding that.
Okay.
Okay, you have any further concern?
No.
Okay.
Okay, are you done with the concerns? You want to examine something else? In the limbs, legs, feet?
Already
Okay.
examine. Okay.
Peripheral neuropathy, you examine?
Yeah, examined the sensation.
Okay, good. Let's go to the examiner question. You can start.
Present your case.
Yeah, this is middle-aged gentleman, Mr. Michael, presented with gradually loss of vision. Okay, mainly affecting the peripheral side. Okay, he has difficulty of seeing the other side of the road. Also, he has a problem in the night vision. Okay, again, apart from this, I didn't appreciate any positive finding in the history. In the examination, the patient has a restriction of the field, mainly in the temporal side, I think, and he has also in the fundoscopy there is the position of specular bone shape, like in the peripheral of the retina. Other than this, I didn't appreciate any sign of peripheral neuropathy, any problem in the cerebellum sign. Okay, and also the hair is intact. The hearing is intact. Yes. So on top of my diagnosis is B retinitis pigmentosa for differential diagnosis.
Okay. And what is the inheritance of retinitis pigmentosa as a mode of inheritance?
Yeah, it is. It could be depend on the cause. There is mitochondrial disease, like yeah, most of them. Yeah, the majority of mitochondrial disease, I think. Also, there is autosomal recessive. I think this X-linked. It is dependent on the cause.
Okay. And what's the treatment for this patient?
So actually, this is something progressive. There is no definitive management, but they can help the patient about educate the patient. There is genetic test, okay, and there is genetic counseling. I mean, and there is some aid, okay. It helps him regarding the to work and for daily life. Okay.
Okay. And you said that he doesn't have a peripheral neuropathy. and the signs. So why you know this?
There is some syndrome like RIF-SOM, right?
Yes.
Yeah, it can associate with peripheral neuropathy and cerebellum, and also some of them they can associate also with some bowel problem.
And what are the syndrome associated with retinitis pigmentosa? We have them and other syndromes.
Usher and RIF-SOM, and there is Albert, I think, and beta lipoproteinemia, this one, right? Beta lipoprotein, I think. Also mitochondrial disease. Albert. I didn't remember it all.
Okay, no problem. Okay. So you did it well. The only and add the good things that you did, you asked about the school's history, you took everything. Of the syndrome, not only the retinitis pigmentosa and the syndrome. You asked about if they have. So you did everything well, but only for when for treatment. Yes, there is no definitive treatment, but sometimes vitamin E. Sometimes they can give him some magnifying glass that can help to maximize the remaining vision, keep them. Sometimes protection from sunlight. Okay. And regular follow-up with ophthalmologist. Okay, this is the treatment.
Dr. Sarah, before commenting, did you ask about investigation? What investigation she can do?
Yes, what is investigation? No, I didn't.
Okay. Yeah, okay, start with the basic complete blood count and renal function test, liver function test, because it can be affected, the liver especially, and the inflammatory marker, a genetic test, okay, and visual evoked, I think we need, maybe, and vitamin A, I think also level, if you can measure, I don't know, and I think that's it.
Okay, so the treatment, I think you will do perimetry for the visual field assessment.
Yeah, perimetry, yes.
And some electrophysiology for the retina. Audiology, you can check retinic acid level for Revzen disease. Sometimes they say molecular genetic analysis.
Okay.
Okay, so this is the and the syndrome associated, you said, right? Usher syndrome has a sensorineural deafness, as you said. And Revzen disease, this is disorder of the photonic acid. They will have deafness, ataxia, and peripheral neuropathy, cardiomyopathy. And low Idle syndrome, they will have deafness, polydactyly, intellectual and learning difficulty, diabetes, hypogonadism, and Kearns-Sayre syndrome.
Yes.
Have progressive psalmoplegia, sometimes cardiac defect.
Yes, cardiac problem, yes.
So this is, we can ask you about, but if you know 2 or 3, no problem. I told you about it. It's the inheritance has different type of inheritance. It could be in 50% autosomal dominant, sometimes autosomal recessive, and some mitochondria, and X-linked recessive. So there is, and I think he will send the kids if he for genetic counseling, and we will see exactly what they will do for them. But I think they will not doing screening test for young children less than 18 years.
Yeah, I think that there is no. I don't because it's not preventive. If there is any something preventive, there is a benefit to doing for the younger one. If it is not preventive, I think if there is develop any symptom after that, they will screen.
Okay, this is my comment. What you need to.
Thank you.
Yeah, thank you.
of inheritance برضه قالت have multiple mode. I think autosomal dominant only.
No, some
No, there is
disease like
mitochondria, there is X-linked.
Kearns-Sayre, one of the mitochondria, and also Friedreich ataxia. It's also X recessive, I guess.
لكن ديل الديسيز الاسوشيتد معاها، لكن هي كريتينايتس بيجمنتوزا.
Okay, let's categorize it as syndromic and non-syndromic. So the syndromic associated with other disease, you have to screen for. A syndromic one, I mean nothing, no syndrome, no disease, no associated condition. This is the one would be autosomal dominant. Yeah, but the others according to the disease itself, because it's included under the syndrome.
is which associated with it.
Yeah,
تمام. لكن إذا براها كبس إنها
exactly. Yes. If
dominant.
alone, yeah, as this patient a syndromic one, right? He has only retinitis pigmentosa, so it can present like this only, without diarrhea, without peripheral neuropathy, without hearing problem, without peripheral neuropathy.
رينال برضه حاجة الألبرت صح؟
Yes,
رينال.
Albert's, yes. So these are the cause, and according to association, underlying syndrome, it will be inherited according to the disease itself or the syndrome itself. Okay. Anyway, thank you, Dr. Sarah, for the case. Well done, Dr. Ibtihal. The analysis, started the analysis well, which is the anything related to the vision, the sight, which eye, I mean, any pain, any trauma, the night and the color. All this question also makes sense to know what you are talking about. In this case, you have the peripheral affection, the night vision affection, the color vision as well affected. Apart from this, yes, you have to screen for the headache, any other neurological condition, and the serious, as usual, we are saying there is complaint and the serious form of the complaint. What the serious form of retinitis pigmentosa or the peripheral vision? What do you think? If you have patient with bumping into the object and you are worried about something serious he might have, what do you think it will be? So let's say the acromegaly or the pituitary
you mean
adenoma.
pituitary adenoma, yes.
Yes, so you have to screen for the alarming, which is acromegaly or pituitary adenoma with compression sign. It will be bitemporal hemianopia, which is not in this case. But the good thing you
because
screen. Yeah.
Yeah, you need to ask about the headache. Any vision problem, you have to ask.
Yeah, so you ask about the headache. That's only to show the examiner you are thinking about the serious association or serious differential or serious complication, which is in this patient adenoma or macroadenoma, which is negative in this patient. Okay, let's go to the possible causes or the syndromes. What you will do, not the system review, you will do this differential exclusion. I mean, let's start from the head till the toe. From the head, you will ask about the hearing. You have two of syndromes will have hearing problem. Usher and Alport and also Refsum. Three of them has or have the hearing problem. Alport and Usher, Refsum. Once you have positive one, hearing positive, so you have possibility of either Usher, Refsum, and Albert. Go to the next system, you will ask about the heart. What you will roll out in the heart? Kern-Sire. So if positive, you will roll in Kern-Sire. Okay, Kern-Sire syndrome. Then we'll go to the GI. What you will have? Diarrhea. Once you have diarrhea, you suspect beta lipoproteinemia, right? Every question will guide you to a syndrome. If you ask, you will get. If you if you rolled out, you rolled out the condition. So if no diarrhea, you roll out a beta lipoproteinemia. Then the last is peripheral neuropathy. When you have peripheral neuropathy, you have two possibilities: Friedreich ataxia and what else? Refsum. And this is the difference between Refsum and Usher. Usher only hearing fiction. I missed the kidney for Alport. So the Alport will have kidney and hearing. Let's start again from the Usher will have hearing problem only, isolated, plus retinitis pigmentosa. The heart or Ken Sayab will be heart plus retinitis pigmentosa, conductivity or whatever, any cardiomyopathy. So you can ask question for any awareness of your heartbeat or any signs of heart failure. Then the genitourinary, I mean for the renal, you will ask about any frothy urine for Alport, and the Alport will be having kidney plus hearing. Okay, you will ask if he is having a hearing aid, or if you search about hearing aid around the patient, or you can only look at the ears. He might have hearing aids in his ears. This is for Alport.
Can examine to do the tuning fork, the Remy and Weber
Of
test.
course, if he doesn't have, you can offer. You can hear this, and you move your fingers. You know the hearing. Just the moving the hands or fingers beside his ears. But if you have tuning fork, you can offer it. Okay, sensory neural loss. Then the diarrhea, you will examine, not examining, you can ask for a history of diarrhea or loose motion. Peripheral neuropathy, you can get either Friedreich ataxia, and in the history you will have Friedreich ataxia in the form of diabetes, also ataxia. So you can ask also about any ataxia or unsteadiness. And peripheral neuropathy, as we know, the the sensation modalities.
Frederick will have optic atrophy, not retinitis pigmentosa on ophthalmoscopy.
But it's associated with some cases retinitis pigmentosa. It's one of the differential. Yes, it's optic atrophy, but it's one of the differential for that attacks. I read it. Okay.
Okay.
These are the possible, and there is one very important we are always missing, which is called Lawrence-Moon-Beadle, and this one will be associated with obese patients, mental disability, and retinitis pigmentosa. Okay. I think also he has thyroid problem, but anyway, he will be mentally retarded, plus obese or morbid obese one, and retinitis pigmentosa. These are the causes of.
And also he will have deafness, polydactyly.
Yes.
Sure.
Yes, polydactyly. Yes, the fifth or sixth. Yes, you're right. Sixth finger in the hand. And this is spot diagnosis, but of course they will not bring patient like this because he will be mentally retarded. Is it clear now for all? So retinitis pigmentosa, sometimes it's nightmare for some candidate, but really it's very easy case to pick up earlier while taking history from the complaint itself. And by certain question or by specific question, you can exclude or you can confirm the association. You might have questioning the patient. One question will guide you to the case. But once the examiner asks you what's your differential, you have to say either syndromic retinitis pigmentosa or the other syndromes. And the other syndromes all are known, starting from Alport as hearing problem plus kidney. I will repeat it again for the last time. Alport, hearing problem plus kidney affection. Then Usher will be only hearing problem. Heart affection will be in Kern-Sayre syndrome. Albert already mentioned the beta lipoproteinemia with diarrhea, and some will be associated with peripheral neuropathy, hearing problem, and retinitis pigmentosa. Lawrence-Moon-Beadle will be with extradactyly and dactyly, and also he will have morbid obesity and mental retarded. Okay, plus or apart from this, you will think about the asyndromic one. Patient will not have any of these, just retinitis pigmentosa. Did I mention the beta lipoproteinemia, which is characterized by diarrhea? Okay, so once you have one of these, you can confirm the diagnosis, or if you don't have all of these, you will have a syndromic retinitis pigmentosa, which is autosomal dominant. Other disease according to the nature of the disease. Clear? Okay. Let's hear the question or comments. Anyone want to comment or add comments or question?
In refsum disease, which acid you said you will measure it?
Refsum?
Investigation-wise.
Any of them you can mention a specific test, genetic testing. Okay. So if you want to start investigation for this patient, you will start doing all baseline basic investigation, just to compare any association, vitamin deficiency or anemia or whatever. But it's not a clue or not diagnostic to the case. Once to finish the general, you can say specific investigation in the form of what? Genetic testing. That's it. You can offer the patient vitamin A, as Dr. Reptihal said, and you can also offer him or not offer. He must stop smoking because smoking progresses the disease more. He must stop smoking, okay? Plus, of course, driving.
Driving also, sir.
Yes, of course, driving more important for the welfare. But smoking for the clinical judgment, you have to stop him driving, smoking, because it worsens the disease. Yes, regarding also explanation of the disease, you can say the nerve cables supporting or coming from the back of the eyes being damaged. I don't know, is it deposition of dye or whatever, but I don't know, is it logic to say that? Or just to say it's progressive damage of the nerve cable in the back of the eye? For me, I will say like that. But if you want to say dye or something, deposition in the back of the eye, I am not sure about this. Okay. And also, if you have some familial disease or genetic condition, no need to mention explanation. You can say patient is having familial condition which is running in family, and it's not preventable one. For the kids, yes, as Dr. Sarah said, whenever they are young or they have symptoms, we can screen them. But for meanwhile, no benefit to screen them. However, we have to mention for the welfare as well. You can tell the patient, for your kids, if they have the same problem, please let us know, or you can bring them to our clinic. What we can offer them, just some supportive measurement and some supportive care, social support, and so on, because no specific medication can help. However, they are trying some antioxidant, which is not according to the guidelines, maybe still under trials. But still, the disease is progressive one and cannot be controlled or even treated. Am I or will I be blind, doctor? Be some sympathetic, Dr. Ibtihalia. I noticed that you are, yes, I'm sorry, you will be blind. Yes, yes, you are sorry, but the feeling of sorry, you are not feeling it. You are just saying sorry, but you are not feeling any sorry. The sorry is not only by saying, even they are commenting in the clinical communication or the communication case that you are sympathetic or not sympathetic. So you have to be like, I'm afraid, doctor, and reduce your tone a little bit. I'm afraid to say yes. There is high possibility to be a blind in the future. Why? Because the disease is a progressive one. Okay? Try to be sympathetic by not by the words, by the tone itself. Okay? And you will do this in the communication as well. Any other question? Any comment? Is it clear? So whenever you have retinitis pigmentosa, you can consider this case scenario as a gift. Don't be panic whenever you see it. And whenever you will see the fundoscopy, it's clear. It's not something imagination. No, it's clear, like the bony spicules, brown or black. It's clear in the fundoscopy.
I just want to ask regarding he will have defect in the peripheral field.
Mhm.
This is the same we can call bitemporal hemianopia, or
No, different.
so what is the difference between bitemporal hemianopia? Because it is the same.
Yes, but let's clarify it. The bitemporal, only he can see the temporal field in both sides. But here you can it can affect the nasal field because the periphery of the all vision, not the periphery, I mean the peripheral field. You got it?
Yes, so he couldn't
Yes.
see nasal and the
Yeah,
temporal,
it's sometimes they are calling it tunnel. Yes, tunnel vision. He
but
can see.
examine
Yes.
the visual field, it will be normal, but all the peripheral visual field will be affected.
Yes, up and down, right and left,
Yes, okay.
or outward and inward. But bitemporal will be only outward.
Outward.
Yeah,
So
this is one of the tunnel vision cause, by the way. It's not peripheral, but he's bumping into the object because the periphery.
yes. So
Yes.
we need to check for the peripheral visual field and the central visual field.
Yes, exactly.
Central will be observed.
You will do the H shape. Yes, you will do the H shape, and it will be affected nasally and temporally. But in the acromegaly or bitemporal hemianopia, it will be only only temporal fields, not nasal fields. You got it?
But why you say H shape? What H shape? There's no H shape.
Yes, the field. How you do the field, visual field by H?
When he will cover one eye, we'll bring our finger from down to up or from up to down.
Yes, it seems like H shape, but yes, it's not H shape as you said, but seems like you are going in the same way of H shape. No, it's coming from up. Yes, you're right, not H shape. Yeah, it's different. H shape for diplopia only, yes. So you are coming from the temporal up, the temporal down, then you cover your eye, then you will do the nasal up, nasal down for one eye, then you cover the other eye for the patient and do the opposite, the other side.
So all of them will be defected.
Yes, all of them will be defected.
And
But
then yes, and then we will cover one eye and put the finger in front of the nose and make it as 4-point up and down, so the center will be intact.
Yes.
Okay.
Okay, clear all?
Yes.
Any other question? Don't forget for the Frederick, you will ask about diabetes signs and symptoms, only polydipsia or any polyuria. Okay. I will share also some notes about Frederick ataxia because it's one of nightmares, but again, I'm reassuring it's very easy case. If you know the specific question for every system or every syndrome, it will be very easy for you. And there are 5 causes. You have to do them screening in the history or in the examination. Okay. Any question, any comments? Yes, it's tunnel vision. I agree. Yeah, nice cases today. Always the eye and vision is nice case because very less presentation. We are not presenting this topic commonly, and it's easy. However, some of us consider it's like, as I said, nightmares, but really, believe me, it's very easy. Once you practice it once, you'll not forget it again. But please, whenever you whenever you hear it, you have to read. So Dr. Sarah, I guess she prepared the case, so she read it already. But who listened to the case today, they should read it once, and I will share a note for Friedreich ataxia, for retinitis pigmentosa. Easy to memorize how to know the causes and the syndromes of retinitis pigmentosa. Okay. Okay, sorry, doctor. We already finished. Yeah, some doctor mentioned phytanic acid. I'm not sure about this medication to screen about. Anyway, if you stuck.
No, phytanic acid to check for Revson.
Refsum?
is phytanic acid.
Okay. Anyway, as I said, whenever you are stuck and you have some certain conditions which are specific or some genetic or running familiar, you can do, or you can say genetic testing. That's it.
Yes.
Okay. So it's one of the specific, and you can get the mark for investigation for this condition. Any other question before ending the session? Any comment?
No, thank you.
Thank you, Dr. Sarah, for the case, and Dr. Ibtihal as well. See you tomorrow, inshallah, with another day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.